Okay, good afternoon, everybody, and thank you for joining us today. We've still got people trickling in, but hopefully by the time I've done my short introduction, we should have everyone. Welcome to today's webinar. Today we're going to discuss next steps in shielding and the COVID vaccination programme and what all this means for blood cancer patients. So we've had many questions come in beforehand, and I hope you guys find the discussion today useful. If you'd like to ask questions, for those of you on Zoom, you can do so using the chat box. If you wish to share it with everyone, there is an option to share it with just the panelists or with the panelists and everyone present. So make sure you choose the option that is most appropriate for you. If you're on Facebook, we are live and we can still take questions from there. Just pop your comment in the comment section and a member of our team will pick it up and through the magic of technology, send it over to me and I will hopefully answer those too. So by way of introductions, I'm Charlotte. I'm the Patient Advocacy Manager here at Leukaemia Care and I will be chairing today's session. I'm also joined by three wonderful panellists. Thank you so much for your time. I wonder if we could start with introductions. Tobias, would you mind just introducing yourself for me?
Yeah, hi, I'm Tobias Menner. I'm working at the Freeman Hospital in Newcastle. I'm typically looking after patients with myeloma, lymphoma and ALL. I'm the CAR T-cell lead and I'm also on the ALL working group.
Thank you for that. Chris?
Hello everyone, I'm Chris Fagan and I'm a haematologist in Cardiff, mainly specialised in chronic lymphoid malignancies.
Thank you. And last but not least, Paul.
Yeah, I'm Paul Moss, a haematologist from Birmingham in the UK, and I've known Chris Fagan a very long time, over 20 years.
Wonderful, thank you. So in terms of the agenda for this afternoon, Paul's going to give a short presentation in just a moment, but we will try and make sure that the majority of the time allocated today is for your questions. So do get them in if you've got some burning questions you want us to answer. You may have noticed just now we've put a glossary of terms in the chat box, which you might find useful to understand some of the technical aspects of our conversation. But if there's anything that you don't understand, you want us to go over again, just flag it to us in the chat and we will make sure we do. So Paul, over to you as a start.
Okay, thank you very much. I will get my slides ready. Share the screen. Welcome everybody. How lovely everybody's been able to join today on such an important topic. So I've got quite a few slides, but I think I've been given 15 minutes, I think is totally reasonable because we want to have so many questions today. So I'm going to talk about COVID infection and vaccine immune responses in patients with a blood cancer. And these are some of the things I want to talk about. I'm just going to briefly show you some interesting slides on shielding. Many of you have been shielding and some interesting facts there. Then I'll talk about BCLL. I mean, Tobias will cover perhaps other disorders, but I'm clinical lead for BCLL, chronic lymphoid leukemia in Birmingham. I'll talk about immune deficiency. Then we'll talk about briefly COVID infection in CLL, the impact of that. Although my colleague Chris Fagan will take a lot of the questions on that. Then I want to talk about COVID vaccines and then how we're assessing immune responses to the COVID vaccine in the UK. So immune deficiency actually is a common condition. Of course, in blood cancer, it can be particularly severe, but if you look at patients with chronic diseases, arthritis, kidney disease, chronic lung disease and diabetes, over 9 million people over the age of 65 in this category. And I should say that, you know, chronic kidney disease and liver disease were very high risk of mortality after COVID infection. And shielding is interesting. These are some slides from the Health Foundation. And during the pandemic, the CMOs across the UK decided to define clinically extremely vulnerable people and advising them to shield at home. As you know, it was initially relaxed in the summer last year and then reintroduced. And of course, as we'll hear in the questions, it's recently been relaxed this week. But of course, there's concerns about the infection risk for this group, but also the costs of shielding. Somebody told me that shielding has not been a widespread practice across the world. I think it's in cocooning in Ireland, but in Europe and beyond, it hasn't been widely adopted. It's interesting how people were initially defined as clinically vulnerable. NHS Digital who have all our health data records, came up with a list originally. And then some modifications were made, and the GPs could also assess individuals who registered themselves. And if you look across the different countries, Scotland, Leeds and Wales, you'll see a difference in the proportion of patients that came from the national methodologies. In Wales, they got their NHS digital perhaps to run most things, whereas in England, some evidence that local, more regional effects came into play. And there's some interesting shielding effects in relation to the different disease. This relates to deprivation. These people here are the most deprived socioeconomically and the least deprived. And this relates to severe respiratory disease, chest problems. And you can see that in Scotland and in Wales, most people with severe lung disease who were shielding were the most deprived group. And of course, that probably relates to things like industrial diseases. If you actually look at cancer, it's actually slightly the other way around. Most shielding was done in the least deprived areas in both of those countries. And if you look at how shielding affected usage of health services, this is probably our groups are probably in blue today, 50 and over 70 in dark blue. And you can see quite dramatic decrease in outpatient use. You see how outpatient use plummeted, both Scotland, Leeds, Wirral, particularly for older people who are in dark blue. But actually, if you looked at unplanned clinical care, going into hospital for emergencies, obviously there was less of an effect. But even here, you can see that these groups were markedly reduced. So trying to avoid even unplanned clinical care. And of course, the impact of that will be important to assess as shielding starts to close. So why are patients with CLL in this extremely, well, certainly in this clinically vulnerable group? I think there are two main reasons for immune suppression in CLL. One is low antibody levels. We've never, as a human population, heard so much about antibodies as we have in the last 12 months. And patients with CLL often have low antibody levels. It goes under this remarkable name of so many letters, I can't even begin to count them, but it's hypogammaglobulinemia, low antibodies. And the other thing is the cells of the immune system are also become rather dysfunctional over time in CLL. Let me just show you some slides to demonstrate this. This is an old slide, I should have referenced it, but it shows that the incidence of low antibody levels in people with CLL, even if they are untreated. So this is watch and wait. And you can see if you watch and wait for 9 years, the proportion of people who are getting low antibody levels increases. So I sometimes think to myself, when we watch and wait, we're watching and waiting for the immune system to deteriorate to some extent. So that's something that we have to think about. And then if you look in patients, antibody levels fall further as the disease progresses. And so here's a control group, early CLL, and then more advanced disease. And you can see that these different classes of antibodies, IgG is probably the most important one, dropping off. And this is one reason why we are concerned about how patients with CLL will respond to the COVID vaccine because of this decrease in antibodies. We're also seeing that the cells of the immune system become disruptive as the disease progresses. Again, this is the same axis, normal people here, healthy controls, early stage CLL and more advanced. And these are the cells that mediate the immune system, the T cells. So you can probably see a bit of a surprise here because in CLL, those numbers are going up. It's very interesting. We don't entirely understand that, but they're probably highly activated cells. They might be fighting chronic infections in these patients, might even be trying to fight the CLL indeed. But as you look at the quality of these cells, you can see that this ratio markedly drops as the disease progresses. And Chris, who's on the line, published an important paper to show that this was a correlate of poor outcome in CLL patients and indeed mortality. So we know that the immune system deteriorates in CLL. And one of the major reasons is that the tumor itself, the CLL B cell, that's the problem in the bone marrow and the lymph nodes, is actually an immune suppressive cell. We tend to think of immune cells as being helping us and fighting infection. But the CLL tumor cell, unfortunately, is quite immune suppressive, and it makes a lot of this molecule called IL-10, which is important in damping down immune responses. Now, you might say, is it, very unfortunate, unlucky that the CLL tumor cell is immune suppressive. It may well be that this is why it can grow and evade the immune system, because it has actually got its own inbuilt defenses from our own immune system. So it can protect itself by releasing these immune suppressive factors. And this is perhaps one of the reasons that as the disease progresses, you see more immune suppression. So let's talk a little bit about the major challenge of the last 12 to 15 months, SARS-CoV-2. And there's the virus, and on the top of it, you can see the red, the spike protein. And the spike protein is the world's most studied and important protein right now, because that is the target of all the vaccines that are currently in use. I'll come to that in a minute. We know that SARS infection in CLL is dangerous and carries increased risk. This was just a review that came out in the last few weeks, and there's just a couple of groups here. They've this paper had 190 patients. This had nearly 200. And you can see really quite disturbing mortality rates in this group. Obviously, risk factors here, increasing age. We know that age by itself is a huge risk factor for severe COVID infection. You all know that. The second one found increased age, comorbidity, asthma, kidneys. We mentioned kidneys again. Those kidney disease as risk factors. BTKs like ibrutinib and acalabrutinib. This paper suggests that they may actually not just be not bad, but they may actually be protective. And certainly the company that makes acalabrutinib was very interested early about trying to use acalabrutinib as a treatment for severe COVID by killing off the B cells in that disease. It probably didn't come through, but certainly it's unclear whether these are bad or whether they even have any potential beneficial effect in severe infection. But Chris, who sees a lot of CLL and has done for many years, will talk more about this during the questions. So what about the vaccines? Well, there are many factors in relation to how people respond to vaccines. This is a review that came out in Blood, a major journal in hematology, in January this year. And it was looking at, this, if you take a control group of healthy older people, you can study how their antibodies work and how they reduce the clinical incidence of the infection. Of course, that's ultimately what matters most, is clinical protection. But in patients with CLL, we've got many things to consider. And these are very relevant to when we go to talk about COVID. The vaccine, what dose, which type of vaccine, what's the frequency, what's the interval between vaccines? We've got age effects. Many patients with CLL, I think average age of diagnosis is 72. So you see that we're already into a high risk group with this condition. Comorbidities, we know that patients with CLL can be more prone to other conditions. There's that word again, hypogammaglobulinemia, low antibodies. How much of importance will those be? And then all the treatments that we have and which have transformed CLL in recent years. Watch and wait, previously treated with good effect, and active treatment with all of these agents that we now employ, actually quite effectively in the management of CLL. This was an interesting paper that looked to COVID, but it wasn't a COVID vaccine. It was assessing in patients with CLL their responses to two different vaccines. One was hepatitis B, you'll know about hepatitis, liver disease, and another one was shingles, which of course we've all had. We had chickenpox when we were young. So that's a booster of something that we've already had. And they looked in patients with CLL. And they looked at patients who were treatment naive and also those who were on something like ibrutinib, acalabrutinib, a BTK inhibitor. And interestingly, the patients who were getting the new vaccine, something they'd never seen before, there was a poor response from BTK inhibitors. But if they were having a booster, shingles, they responded quite well on BTK. I've got a representation here. People in red here are on ibrutinib, and this is their antibody responses. You can see not many reds are getting up into this good zone. This is a response to the hepatitis. This is the new, fresh virus they've never seen before. So ibrutinib was bad there. But when we were boosting the shingles, the zoster, you can see that ibrutinib did not have a major effect. It almost seems to be if you've got an immune memory to some virus, then maybe you can boost it quite well on BTK. Now you might say, well, how does that leave us with SARS? SARS is, of course, a new virus. So you could say it pushes it into this territory. But you do probably know that there are many other coronaviruses that we all harbor. There's 4 of them commonly circulating, and they cross-react to some extent the immune responses with SARS. So you never know, and we'll have to see what we find. And what we've seen in the last 3 months is incredible progress in vaccination against this virus. Like there it is again, and those are the spike proteins on the surface. And that's the spike. You can just look at a rather beautiful globular domain of this protein. And we need to make antibodies to this region here. This is the bit of the protein that binds to your nose, your airways, and gets into your body. And vaccination is all about making antibodies that block it, just like Velcro on the top, and stop the virus sticking to your cells. And my colleague Gavin Screeton in Oxford, he's actually mapped where these antibodies sit. So these strings here, these are antibodies. These are actual crystal structures of how antibodies are sitting on the spike protein. Some sit straight on top. You can see why that stops sticking onto your nose. Some stick on the side, but they can still be effective. So we now know how antibodies bind, and with vaccines, we need to make them. So we've got 3 or 4 vaccines now, and they're all looking very good so far against COVID. Now, one of the rules of biology, they're probably the crown jewel rules of biology. I'm sure Newton would have his physics laws, but in biology, these are our laws. DNA, you got that from your mum and your dad, maybe 60, 70 years ago. That, when it wants to use itself, it makes little copies, blueprints, if you like, for small sections, friable little copies, carbon copies called messenger RNA, and they are decoded into proteins. Most vaccines used to be proteins, sort of a little bit like egg white, injecting a little bit of egg white into you. But now one of the major vaccines, the Pfizer vaccine, is actually just the code. It's an mRNA. So it's very interesting new vaccine. And there you are. These are the vaccines we've got. The mRNA, Pfizer, Moderna will be coming into this country in about a month. The AstraZeneca vaccines, which are really quite immunogenic and strong. AZ, of course, in the news all the time, and Janssen. There are many others as well. This is the very important paper that showed the efficacy of this messenger RNA vaccine. The vaccine was given here, and in blue was people who had not got the vaccine. They were the control group, and this was a number of new SARS infections, COVID infections. And this group in red had got the vaccine. And you can look at the efficacy. We're looking at 95%, over 90% protection. Fascinating, if you look in this very early period, this protection is kicking in at 11 days after the first injection. Very, very early, you're starting to see this plateau. Now, of course, viral variants, mutations, if you like, are a concern. This is a complex graph, but if you just look at this here, what it shows is we start with one virus here, and then all these different subtypes splinter off. It's what we call a phylogenetic tree. It's the sort of thing Charles Darwin started when he was looking at evolution. All these viruses are related, but different ones are growing up. And of course, as we know, Britain, we have this Kent variant, which started around November, December, and took over, and is creating the 3rd wave around Europe. Now, what about blood cancer? This is a paper that you will have seen. It's called the SOAP study from King's. It was about 95. It looked in controls and patients with solid tumors and blood cancer. The headline results, let's look at the cartoon first here. Here's healthy controls, here's the solid tumors, and here's the blood cancers. And you can see that in blood cancers, the response to the vaccine is lower. So that was the concern, that after one dose, this is one dose, there is a lower response in patients with blood cancer. A few things we have to take note of here, though. The median age of these patients was 74 years, quite old, elderly, and 50% had received treatment in the previous 14 days. These patients were largely recruited in hospital. They were having things like rituximab, chemotherapy, and BTK inhibitors. The control group were not age matched. These were not people in their 70s. I don't quite know what they were, maybe middle-aged, 40s, 50s. So they weren't an ideal control group. So it was a heavily treated elderly population, but of course it has led to concern, and justifiably so, about the delay to the second dose. With the help of charities such as Leukaemia Care, we've started a CLL vaccine study, initiated a study of antibody and cellular responses across the UK. And as I say, we've had tremendous support from Leukaemia Care and others about recruitment and publicity. To date, we've had 800 patients who've registered interest. We've consented around 450 and sent out samples for home blood testing. We've had 300 back, and I think 260 of those have been analyzed for antibody measurements. And we're currently analyzing the results. It's really just too early. We want to get this data out as soon as we can, because this is for policy. But we're looking at, in the next few days, potentially next week. I think this is the largest vaccine study in the world on CLL. And some of the questions, will watch and wait have a different response? What about BTK and venetoclax? Should you vaccinate prior to therapies? How long can we wait? Sorry. What's the impact of previous treatment? What's the best vaccine? We compare AZ and Pfizer. What's the best time interval? And so, there are many things that we need to address. And finally, of course, what about people who get a poor vaccine response? What do we do then? And some of you may know that it can be possible to give people antibody infusions and injections to give them protection, even when the vaccine has not worked. And of course, we only heard yesterday, positive news, vaccine prioritization for adults who live with people with blood cancer, at least in England. And of course, it's often said that clinicians can recommend patients for early second vaccine with blood cancer. And Chris and I have had some success with that, although it's not complete. So in summary, I'll finish up slightly over 15 minutes, but I would say shielding has been widely adopted in the UK, makes a lot of sense to me. And there's currently a lot of assessment of its efficacy and the challenges and problems that it might have brought. People with CLL have immune deficiency. We're starting to understand why antibodies and cells are impaired, and vaccine responses are impaired. SARS-CoV is a challenge, we know that. And now we are assessing the best vaccine for this patient group, and also guiding the next steps when those vaccines do not work. I'd just like to acknowledge my colleagues who've done so much work on this CLL vaccine study, in particular Helen Parry's clinical lecturer, Rachel Bruton, and the manager in the group. And they've worked tirelessly with colleagues, and also Alex Richter, who's helping on the dried blood spot tests. And I will stop there. And obviously I'll be taking questions during the meeting. Thank you.
Thank you, Paul. Yeah, wonderful overview. And I think some of the questions you put up at the end definitely resonated with some of the things we've been hearing from patients that they'd like to know. So hopefully some answers soon coming. It's good to hear your study might be coming out in the next week. Okay, so that largely covers CLL. And I think my first question would be to you, Chris, if that's okay. Specifically around some of the slides Paul presented around the immune system and the scientific reason why CLL patients are vulnerable. What do we know about the differences between CLL and other blood cancers? And are there other particular groups we know are also at additional risk that people should be aware of?
So I think there's several things one needs to bear in mind. Not all cancers are the same, not all patients are the same by a long shot. The things that tend to make you more prone to infections and immunosuppressed is clearly age. Our immune system ages as we age. We didn't really evolve to live to the age of 70, 80, 90. So our immune system wasn't necessarily built to last this long, albeit it's pretty good. And the majority, different diseases affect your immune system differently. Ironically, acute myeloid leukemia isn't that immunosuppressive up front the day you first present, other than certain sorts of infections, fungal infections, are very dependent on neutrophils to kill them off. That's much more relevant to acute myeloid leukemia than it is to say CLL. And then you talk about the actual therapies themselves. We all know about rituximab, obinutuzumab. They're very immunosuppressive. They're designed to kill B cells. That's their job. But we know purine analogues, fludarabine, cladribine, which are used in myeloid and lymphoid malignancies, are very good at killing B lymphocytes and T lymphocytes. So we would expect that pre-treated AML patients who have purine analogues will be getting immunodeficiency along with their older age. And as Paul touched upon, those comorbidities matter enormously. Do you have diabetes? Do you have normal kidney function? It's also a question of your bacterial or infective load. If you've got COPD or whatever, you're probably carrying more fungus and bacteria than normal. One of the interesting things with COVID, and what we used to worry about an awful lot with flu, is secondary bacterial infection. And it appears, although that can happen with COVID, I don't think it's at the rate that we would expect to have seen in a normal flu pandemic. We are seeing some patients, of course, and they're probably pre-colonized with bacteria, but it's not quite that rate. The things that make you ill with COVID are unique things. It switches on your immune system in ways which is unhelpful, and you get an inflammatory response to it. So ironically, when you look at the ibrutinib data, does it protect against COVID? It may actually be protecting against that inflammatory immune surge you get, which what with COVID can damage the likes of the heart, the lungs, the muscles, the kidneys. So it is actually a very complicated set of factors one is thinking of. But in general, chemotherapy is not good. Some chemotherapy is worse than others. Older age is not good. CLL is not good. So we would expect, for example, an AML patient at diagnosis probably not much more prone to COVID than anyone else. But actually, if they go through their therapy, they'll get more prone to COVID. A CML patient, we don't really have much in the way of data. It's a rare disease, and we just haven't got enough data yet with CML. But normally, CML patients are not that immunosuppressed, and imatinib and such like are not that immunosuppressive as agents. So I think if you're a patient, if you've been given prophylaxis with acyclovir or cotrimoxazole or something similar, that's a proof that your clinician thinks you're quite immunosuppressed. If you're not on those, and very few CMLs are, for example, your clinician thinks you're not particularly immunosuppressed. But the data through the likes of Paul works and the King's works out individual diseases, CML, AML, etc. We just need more patients and longer follow-up at the present time.
Yeah, great, thank you. Oh, sorry, carry on. I didn't. I interrupted you.
I was just going to say the King study Paul highlighted, the healthy controls were in fact healthcare workers. Okay. And of course, what we also know with them is many of them may have had COVID earlier on in the pandemic before they got their vaccine. They may have actually got an exaggerated response, but I think they're younger and maybe they've self-selected in a way as well, which are not, so they're not quite shielding patients is what we probably saw with the solid tumor people and the blood cancer people. But I think it's fair to say everyone was surprised at just how low blood cancer response was. That was a surprise to me.
Yeah, we'll come back to that paper because I think that the bulk of the questions we've had in advance have been around sort of the results of that. So we'll come back to that definitely. Tobias, I think you missed the question I asked Chris a moment ago. Yeah. But basically what I was saying is Paul gave a very good presentation on the reasons why CLL patients are particularly at risk from COVID around, the science of the immune system, and Chris has just sort of given a flavour of why CML and AML may not be the same. Is there anything you wanted to add from an acute leukemia perspective about the risk factors for COVID and what we know now that we perhaps didn't know March last year?
I mean, it's difficult. I mean, again, there's very little data for ALL and AML on this and the whole and MDSs. The same is for multiple myeloma. For multiple myeloma, there's some data that people who have multiple myeloma at increased risk of dying from a COVID infections. Lymphoma patients, again, the whole spectrum is so huge. Some people have been treated, some are currently on rituximab, which will certainly immune suppress you. Some, like patient with mantle cell, will be on BTK inhibitors, which will suppress you. And then obviously some patients have extremely intensive chemotherapy, which on its own will be very immune suppressive, especially a lot of the chemotherapy contains vincristines, vinca alkaloids, which will suppress your T cells and your B cells, and steroids. So there's a lot of things which will immune suppress you. And I think at the moment, we still don't know enough what the influence of chemotherapy is. And at the moment, there's actually now several studies happening in cancer patients and also in lymphoma specific patients, where we will check the antibody responses, where we will check the T cell responses after vaccinations. But what we can say is that clearly, since we started the vaccination program, the numbers are going down, and we have less and less patients who present with COVID of our patients. I mean, I can't remember when we admitted last time a patient with COVID. Of one of our patients, it's weeks, and this is due to that we started with vaccination. I'm not certain if this is because the patients have immunity, or is it because all the other contacts have also got vaccinations, therefore they are not spreading it anymore, and that's something we need to find out. This data is not out there yet.
Mm-hmm. Yeah, but I think that's an important point. There's still a lot we don't know. I think we're having this conversation today at a point where people will be tomorrow in England and Wales at least considering going out a bit more. But that doesn't mean we have all the answers at this point in time. Paul, I wanted to come back to you very briefly. So Chris and Tobias and you there have outlined that the risk of COVID is different in different groups. Does that correlate with the groups who are least likely to respond to the vaccine as well? Is there a direct correlation, or is there a slight difference in those two groups?
We don't, obviously, as you said, it's annoying, isn't it, today that we have so few, we don't have all the answers, so that will be a recurrent answer, that we don't have the data yet. I mean, incidentally, you know, because the UK's led, being one of the leading countries on vaccine rollout, we should hopefully get many of the answers more quickly than other countries. Only Israel perhaps has been ahead of us. America's doing very well now as well. So we are working hard to get the answers. So we don't really know. You would expect it, I think, because if you take a condition, I mean, as Chris was saying, chronic myeloid leukemia, for instance, you don't tend to think of that being a condition of immune deficiency, whereas CLL is. And we know that vaccine responses, pneumococcus, influenza, all those things we've been giving are weaker in patients with CLL. So, you know, it would be surprising if there were not some deficit in the vaccine response in CLL patients, to be honest. However, you know, these are new vaccine platforms. The mRNA vaccine has never been used before in a global setting before. It's very strong. And we've done some work, I think it's probably the biggest cohort in the world of older people between the age of 80 and 96. These are independently living healthy controls. And we're seeing very strong antibody responses with this vaccine. And this is a group where you would have expected poor flu responses. So yes, in answer, I've said a lot, but I do think there will be a correlation between susceptibility to infection and poor vaccines, but we haven't quite got the data just yet.
Yeah, and that brings us back round to the paper that got all the media attention, I think was last week or the week before. The time frame escapes me off the top of my head, but we've had a few questions about that. One of them, I guess, is we've heard a lot about antibodies, but is there anything else that's important to the immune response? You sort of touched on T cells and things. I wondered if you could elaborate slightly on what is important and what constitutes a good immune reaction, I suppose.
Yeah. I mean, I really ought to talk about T cells. That is my thing, to be honest. That's what I worked at most. Chris is grinning. But yeah, I have worked on T cells a lot. I do believe in them. And you know, a virus, once it floats around, your antibodies can stick to it like Velcro and neutralize it. That makes sense. But once it's got inside your cell, the antibodies just can't get at it. And then you need the cells to come along, because they use digital recognition. All of your cells are exposing their contents all the time. They constantly do that to show viruses to your immune system, and then the cell can kill it. And so I do believe that cellular responses will be important, and things like influenza, they seem quite important in controlling the disease. And so what we're seeing with the early data of the one vaccine in older people across the UK is that we're getting high control against infection, 50, 60%, but much higher even against death and severe disease, 80%. And I think that's showing that the cellular response is kicking in these people and helping to control the severe disease. That's my hope. So
coming into our hematologist, Tobias, I mean, so the paper that was published, the headline results was that the antibody response in hematology patients was low, but there was a hint in if you read slightly further than the media articles, that T-cell responses were looking at more positive than antibody responses in hematology patients. Is that something you see in other patients, and are T-cell responses strong enough in blood cancer patients that could make up for it?
I mean, it all depends also on what treatment you have, and it will be different depending on what treatment you had and what underlying disease you have. I mean, at the moment, I have to say, I found it a bit difficult because it's a really small study with very few patients, and I think it got too much publicity and probably got also too much, it was a bit of a scare story, which I don't think was helpful. I think they should have waited and got a bit more data and got a better healthy control arm and things like this before they come up with a statement. At the moment, we just have to wait. I mean, we're starting just now a study which is run by Southampton called Prosecco for lymphoma patients, where we look at patients who are on treatment, who are off treatment, and those who never had any treatment. And for every possible lymphoma, from T-cell lymphomas to low-grade lymphomas to high-grade lymphoma, and we're getting from 1,000 patients blood samples. And the same is happening in cancer studies and obviously in the CL area. And there's a study just for cancer patients in general. And this will take a few months, but you will by the end of the year, we will have it. And realistically, I think what will probably happen is that a lot of our patients, they will get their second dose, and then they will be recommended to have a third dose. And at the moment, we all try to space it so that they have, if they have rituximab, we try to space it just before they get the next rituximab dose. So have at least a week or 2 weeks before they get their next rituximab dose. We try to space it within the chemotherapy. At the moment, I would still give it, the treatment, rather than wait and not give it until they finish the chemotherapy. But you need to try to space it in intervals where there's probably less chemotherapy around, less antibody around. And you just need to do it experimentally and just try. But somehow, whatever we do, it seems to work because the numbers are going down. And that is very clear. I mean, we had only, the death rate is now, what, 19 patients a day, 20 patients a day, when we were at thousands just a few months ago. So this is certainly improving, and the number of COVID cases are going down.
Chris, anything you want to add on the point about what this paper actually means in practice?
I think it was a fascinating paper. It probably was a bit premature, especially the headlines. I wouldn't blame the researchers for it, because it's a massive contribution to our knowledge, both confirming what we suspected or even making us rethink maybe our preconceived ideas of what would happen. But certainly the figure was very low for hematological cancers, much lower than, as I say, I expected. But on one level, we know that viruses can be a problem. It's just usually annually, year by year, we don't really have many people who are very, very ill with viruses in hematology. Paul know about CMV, post-transplant's a completely different ballgame. There you really are starting from scratch. But CMV, for example, which is a very common virus, it doesn't usually cause too much trouble for an AML patient, a CLL patient, a lymphoma patient in general. So normally we haven't paid much attention to viruses because it's not a big clinical issue. The thing that is a big clinical issue is actually flu. That is a serious problem to haematological cancer patients. And every year in the UK, it's about 25,000 flu deaths a year. We've not seen flu this year at all. I think there was 200 cases in total in Wales of flu. Normally that would be thousands every year. And the reason why the flu isn't here is because we haven't been traveling around and we haven't been mixing the way we were. So we haven't had that annual flu thing. But usually flu doesn't register with us because it is the much more elderly who succumb to flu. So maybe we should have paid more attention in the past about that response to flu. Although the diseases are different in the way they're threat to your life, in the multi-organ failure you can get with COVID, which doesn't seem to be such an issue with flu. I think now, dare I say, the people over the next few years are going to be phenomenally important are the flu doctors and the flu researchers. It was just less of a problem, but I think that story will tell us an awful lot about the way blood cancer patients manage viral infections. Memory T cells that Paul touched upon, we probably see a bit of flu every year. There will be cross-reactivity. Whether this COVID is so very different to the previous coronaviruses, we've just been caught out, or whether there's something unique. It will all unravel in due course. So we're much better prepared going forward, but maybe we should have paid more attention to it in the past, and maybe we have.
I think the other outstanding question from the paper is around the timing of the second dose. So my understanding of this particular article is that the vast majority of the people had just the single first dose, and those who did have a second dose had it earlier than the current protocol that's in place in the UK, which was 12 weeks. And what the researchers suggested would help would be a earlier second dose for certain patients. Paul, I wondered if you could start by commenting on what the paper said about the dosage and whether there is a case for a change there.
Yeah, very reasonable. I think actually the paper states that there is too little information in blood cancer to say anything about the second dose. I think that's quite clearly in there, interestingly. But nevertheless, we can speculate. So remember these two big vaccines we're dealing with, the Pfizer mRNA, the one that I talked a lot about, that is being trialed as a 3-week interval. And that's what they're using in America and most of Europe, of course. And so there's a lot of data for that as a 3-week effect. And so I think there is a case really for earlier vaccination. We know the reason why the UK has gone for a delayed vaccine for population coverage. The other vaccine is AstraZeneca, and you've been probably following over the last few months that there's evidence that it seems to work. Well, the second one looks better if you leave it a little bit longer. So, I think to bring the AZ forward is, perhaps less clear, to be honest. It will provide you with a boost, but it might not be as good a boost as you might get if you waited the proper length of time. That's a more difficult decision. And Chris and I were talking about this just before we came on. And I think the Joint Committee on Vaccines and Immunization would say that, physicians can recommend, at least try to get the second dose earlier for at-risk groups. Certainly for the Pfizer, that would make sense. I've managed to do that sometimes. Chris has tried as well. Occasionally it works, but obviously there's national pressures to roll out across the population. And so it's been difficult, but it can be something that's tried. And I imagine some people on the call probably have benefit from that, I hope.
I think that's an important point you made there at the end, Paul, about every person who has a vaccine means another person may not be able to have a vaccine. And it is a really difficult decision for the Joint Committee to make. Obviously, we're here to talk about the interests of blood cancer patients, but it's always important to have the wider decisions at the back of your mind. Chris, did you want to expand on Paul's point around how successful you've been in asking whether your patients can have the second vaccine earlier or not?
It is a real difficult one. In normal situations, what you would do is vaccinate half your patients on day one, then half of them would get it when the trial said they should get it week 3 or week 4 in the case of AstraZeneca or Pfizer, and compare that with those other half who get it at 12 weeks, because Paul's absolutely right. If you go too soon, you actually may not get as much benefit from the second dose as you would think you should. So in an ideal situation, you do a randomized study, and that would tell you whether what you gain by getting probably the antibody level up earlier was offset by the magnitude of the secondary response. A bit of me says, and Paul would better to comment really, is the T cell response was better than the antibody response, even after the 1 dose. So is that really telling us that actually whether you get it at 4 weeks or 12 weeks, you're going to get a boost in it because your T cells are certainly switched on to this, this virus or similar virus that it's met in the past? Anyway, so we're in uncertain times because we haven't been able to do the studies in the normal way. I think one very important thing, if you take the annual flu jab, and sorry to talk about CLL for those people who don't have CLL, but they probably are the most studied group of patients, only to 15 to 25% of people respond to the annual flu jab with CLL. It's very low. The most important thing is their partner who doesn't have CLL and those around whom who don't have CLL, that they get that jab, because that herd immunity, where is our patient going to catch it from? It's those closest to them on the whole. And we knew that even through COVID. Most of it is once it had penetrated the front door is when problems really, really happen, because we all live together indoors. So that bringing forward, that getting your relatives done early, if possible, in England. We haven't done that in Wales yet. But to me, is it important the patient is done earlier? Maybe. But actually, it's just as important, if not more important, than those people you live with, if they've had their 1 jab, getting their 2nd jab. Because it may be you're not going to respond to the 2nd one. You had a poor response to the 1st and poor response, but you would certainly expect your partner who doesn't have the same immune system to respond better. So back to a limited supply and what you're trying to work your way through the best use of what is available. But it's a scientific thing. We haven't proved that 4 weeks is better than 12 weeks for either vaccine, but certainly evidence for AstraZeneca is it may be better to wait. So that may be true of patients with blood cancer as well as those without it, but we just don't know that. But certainly trying to get your partners done. So as well as haranguing your physician about can I have my vaccine early, is can you get their GP also to get your partners and those who live in the house with you done early as well.
Anything you want to add, Tobias, to those?
Yeah, I think it's important to get the herd immunity. We know from the data from the COVID vaccination and the RNA virus that even after the 1st dose, a lot of people get already extremely good immunity and good responses. And we can see this on the charts which Paul showed earlier after day 11. So that's well before you had your 2nd dose. You already have started to see the flattening of the curve and of getting serious infections. So 1 dose is probably the crucial one. To get 1 dose in first is the crucial one. In Germany, interestingly, based on the recent AstraZeneca data, they now give 12 weeks of AstraZeneca as well. They don't give any more 3 to 4 weeks. And that is also to increase herd immunity. So they adopted the UK approach now. They haven't done it for Pfizer yet, because Pfizer, there's no data. But they can understand why they've done it. And realistically, because your immunity to this RNA virus is probably quite good, so I would imagine you will have a response like you have for the other AstraZeneca, where you still have immunity after 11 weeks. You will probably get the same thing for the Pfizer one. And you could just see that you will then just get a boost again after 11 weeks. And I could see that it might be even better.
Yeah.
So I would be less concerned about it, but it's crucial to try to get everyone vaccinated. And so one of the things I now recommend to my patients I see is to try to get everyone else within the household vaccinated as quickly as possible. And I still say you need to be careful. You still need to be careful. You need to until you got your 2 vaccines in, and we still don't know if this will work. You need to be careful, protect yourself. Don't just think suddenly because you have 1 dose, you can around now and you will be immune. We don't know this. And
Yeah.
so you need to be sensible until the whole thing is, until we have at least 80 to 90% of the adult population being vaccinated.
Absolutely. Yeah. So yet more uncertainty, unfortunately, everyone, but I hope you find that useful. Just to clarify the situation around the household, as Chris said, there was advice from the JCVI yesterday that the English NHS has taken up already that household members should be vaccinated. So if that applies to you, if you live in England, you can now request that your household members be vaccinated. I believe that they've also issued advice to the other devolved nations, but they haven't yet taken it up as far as I'm aware. But that doesn't mean you shouldn't ask. I would encourage you all to ask. And as Chris and Tobias have described, it's good news that the importance of the herd immunity is being recognised now. I think the next question I wanted to ask is around antibody testing, and I'm going to put this to Paul first, if I may. A lot of the questions we had in advance were, how can I find out how I have responded to the vaccine? Should I be getting an antibody test? And I guess this is important in light of what we were talking about before in terms of antibodies and T cells being important. But what's your advice to people out there thinking about whether they can find out if they've responded or not? Should they be trying to do so?
Yeah. It's a very interesting question, and there's no easy answer to this, I think, unfortunately. What the world wants is what we call an immune correlate. So something about the immune system that we can measure that correlates, that predicts protection. You know, those things in any vaccines are very, very difficult to define. So we now give all young women HPV, papillomavirus vaccination against cervical cancer. It works wonderfully. We don't really know what the immune correlate of that is. We think it's antibodies, but we don't know what level. So it's actually a hard thing to define. It needs very, very big population studies. So that's what we want. And then we want a blood test to say, look, you don't reach that level, you're at risk. Let's think about what we can do. So we don't have that yet. So I can totally understand why people are interested in their antibody levels. It's difficult to know exactly what you do with it. Maybe the level is quite high, but you know, you're only measuring antibody that sticks to spike. Is it really functional? Sometimes in CLL, they're not so functional. So you may not be protected. And of course, that might give people confidence slightly to take more risk. And in all these studies of vaccines, by the way, it's been noted that once you vaccinate people, they do tend to go out and about a little bit more. And that's having to be taken into the analysis of vaccines. So on the one hand, there's false positive news. And then if an antibody is not detectable, well, you might have a cellular response. And if you were lucky enough to get an infection, there may be a memory there that can be boosted. So we really don't know what to make of it yet. And that's why everybody is in many groups, in normal healthy donors across different ages, and in CLL, we're trying to measure these things and correlate it with clinical outcome to try and get that information. So the study we're doing, we're not allowed to tell people the antibody results, and it's very frustrating in many ways. And many people have, you know, some people decide not to take part because that, you know, that they find that disappointing. And I totally respect that decision. But I suppose, you know, the ethical challenge is we don't exactly know what that level means just yet. And so that's why we have to be a bit cautious. You can get it measured. I think certainly privately, there are companies now offering this, digital blood tests at home and so forth. I mean, I can't say I could recommend how to interpret those results, but, you know, that's a personal choice.
Yeah, I think that's the thing that everybody isn't quite clear on, is the interpretation of them and how uncertain that still is. I think it's an important message. Tobias, you mentioned that you are testing people in your work. Is that purely for research purposes, or?
Yeah, that's true. I mean, we're just starting to open a study for lymphoma patients where we will just check the antibodies after they had the second dose. But that's poor research, and it will be anonymous. The patients will not get the antibody data, and it's just to get an idea what happens to 800 to 900 patients in the study. This is 5 big centers in the UK who will do this, and we collect patient samples for 2 months, and then they will be analyzed, and hopefully by the end of the year or by the third quarter, we will have an idea of what's happening with antibody response and kind of immune responses. And this will be obviously then get published. But that's, we don't know at the moment. And it's very difficult to, yes, we all assume it will be not as good as in a completely healthy patient, but how significantly worse it is something we need to see. If it's really as low as the King's data, that's something we have to see. And we need to see also what happens once you have the 2 doses. But realistically, I can see a time when we will have regular coronavirus vaccines, because you get more and more new phenotypes with new variants, and you get the South African variants, the Brazilian variant, and they will spread at some point as borders will open. This will spread. And so I think what will happen is we will come to a point where we probably have not just the flu vaccine, but we will also have a coronavirus vaccine, and on a yearly basis, or at least for the next few years. And the government already speaks about a 3rd vaccine for the high-risk groups.
Mm.
And I think will happen, that people will be offered a 3rd vaccine if you're in category 1 to 4, and which is cancer patients.
Yeah. Just the question has popped up in the chat box. I think it's quite a useful one to go back to straight away. Paul, someone's asked, then if the antibody tests are not useful for measuring the response to the vaccine, how come they are also being used for measuring the response to natural infection? And is there a difference between those 2 usages, if that makes sense?
No, it's a very clever question. Obviously, natural infections, a number of interesting things about natural infection. Of course, with natural infection, you get a response to the whole virus, all its proteins. And so you get a much broader response against the virus. In case you ever see it again, you're much more prepared for it. What we're seeing actually in older people in particular is that those people who have had a coronavirus infection, of course, in the older people, those are the survivors of a severest disease, they get fantastic vaccine responses actually. And in fact, there's sort of outreach, the so-called infection naive group, they have tremendously high quality vaccine responses. It's almost, if you have had a COVID infection, there is something about it that's actually potentially quite positive for your vaccine responses in a way. That's quite interesting. No, I mean, I think the type of antibodies that you get after a natural infection are much broader against many proteins. After a vaccine, they're only against the spike. We do measure antibodies against the spike. Those are almost certainly going to be, I think, the immune correlate of protection against infection for sure. Disease, as I say, I think cellular responses will matter. When I said that you might have antibody responses, but they may not be that protective, you just have to be a little bit careful, because we need neutralizing antibodies and valuable antibodies. Sometimes in some conditions you can see antibodies are not so effective, but that's a very hard test to do on everybody, quite frankly. So I think antibody measurements will be the thing we'll go for. But just a little bit of caution about, we don't know the cellular responses in these people. And I don't think at the moment that's licensed for, decreasing risk too much in terms of how you live your life.
Absolutely. I think that's a good message for everyone. I'm conscious we want to move on to shielding as well, but there are a few outstanding questions around vaccination. I might fire them at you, Paul, if that's okay. In terms of the difference between the different vaccinations, this one comes up quite a lot. Obviously, there is nobody can choose to have a particular one unless they have a clinical reason to do so. But is there any evidence of any benefit from one over the other? And also about mixing vaccines, people are still concerned about whether they'll receive the same one at 12 weeks and whether that makes a difference.
At the moment, everybody's getting the same. There's no mixing at all. So there is a study going on of mixing, by the way, and that's, I think it's 680 people. It's run in Oxford. I'm on the actual data management group for that, but that's a research study. So in the public, everyone's getting the same vaccine. In terms of comparison, we're actually doing a study right now where we're comparing AZ with Pfizer in older people, and we're seeing some interesting results there, and hopefully that'll be out, in the next week or so. but they're both very effective vaccines for immune responses. And that makes sense because if you look at the epidemiology already, we're seeing that both vaccines are giving, after one dose, over 80% protection against severe disease. And so they're both highly effective.
And
Can I
oh,
just
sorry,
add,
Chris. Yeah, carry on.
I just add, what people don't appreciate is the two studies, the AstraZeneca and Pfizer, that were actually very different studies. In the Oxford study, having had the vaccine, they were swabbing everyone twice a week and looking for virus. That wasn't happening in the Pfizer study. They were looking for clinical infection. So you're not really comparing like with like. And unfortunately, when all these things come out in a blaze of glory in the press, these nuances, which are phenomenally important, don't really get appreciated. And Oxford was originally 70% effective and Pfizer was 90 odd. You weren't comparing like with like. And they're both aimed at producing the same protein. They're both aimed at producing the spike protein. And in theory, if they're equally effective, they should both produce the same spike protein, albeit maybe in different quantities. But to say one is better than the other and to get hung up on that, I think is actually a mistake, and it doesn't really appreciate these studies were very, very different.
Yeah, that's an important point to make. One of the common questions we get is, can I tell how I've responded from things like side effects or from sore arms and things like that? Is there any correlation between how you respond to the vaccine and your actual response in terms of your immune system?
I think there is a bit of data, on this Zoe app. I think loads and loads of people, maybe millions across the UK, have been reporting symptoms of COVID infection and on an app on the phone. And it's a really big data study. And of course, many of those patients are now having vaccines. And it does seem to be the case that people who've had a previous infection get more symptoms when they have a vaccine. So that makes some sense. The immune system is there, it's kicking off when it sees the vaccine, and it's more inflammatory, more inflamed. So that makes some sense. And we know that those people are making particularly strong immune responses. So it does sort of, to me, make a little bit of sense, because the immune system likes danger, it likes inflammation. That's when it really gets going. It's tempting to feel when you are a little bit feverish and inflamed that you get a better antibody response. But I don't have any data for that in COVID vaccination. But if somebody in my family was saying, oh, I feel a little bit, they wanted reassuring, I'd say, well, hopefully this will mean you've got a stronger antibody response. I don't know, but it certainly makes some anecdotal sense to me.
Yeah. Okay. And then I think the final question we'll do on vaccination, because I'm conscious we've got plenty of other questions to cover, around the variants. How concerned should people be about their protection against variants, particularly in light of some of the news around Europe in the past week or so? Should they be worried about those variants coming here and being protected against those?
I'm happy to take that one. I think we do have to be rather concerned. There's all these different variants. Couple, that we hear a lot is one from Brazil and there's one from South Africa. And I think Brazilian one may not be so bad. Some of our own data and others suggest that might be okay. But South Africa really does seem to evade the immune system quite well, our current vaccines and maybe even our current people who've had viruses. So we have to be careful about that one. And that is, there's two approaches. Either you can get your vaccine so good that your antibody levels are sky high, so there's enough to cover everything just because they're so strong, or you can do a vaccine against South Africa, and that might be, as Chris said, the autumnal boost. Maybe we'll get a slightly different vaccine that has that, or maybe it'll have South Africa and the Wuhan, whatever. So there's various ways we can address it over time. But in the short term, I think it is something we have to be very careful with.
I think it's important to remember that the vaccines work well against the most common variants we have at present, and people shouldn't worry overly about that for the time being.
Currently, the one in Europe is actually the Kent one, which is covered. We know this already. The AstraZeneca and the Pfizer, and also the Moderna covering the Kent one.
Yeah. absolutely.
And the problem they have in outbreak is because they have in Europe just the vaccination rate is so much lower than in the UK.
Yeah, and I think concerns raised in the media are more about another variant developing rather than there being an actual variant at the moment that we don't already have in Europe, is my understanding of the situation. Absolutely. Moving on to shielding a little bit then. So I forgot at the beginning to set this out, so I'll do it now. So shielding is pausing, which means that all the guidance that's been in place over the course of lockdown around staying at home and not going to work if you've been shielding will end on the 31st of March in England and Wales, and in Scotland on the 26th of April. And we don't currently have a date for Northern Ireland at present. We're expecting an announcement in the next week. So obviously this has caused some concern as well as some happiness among some people. I can totally understand that people are split in their reaction to this news. I want to get the thoughts of the panel on what people who've been shielding should do next, I guess. We've had lots of questions about, should I do this? Should I do that? Tobias, I'll come to you first. How should people take the news of shielding pausing, and do you have any advice for patients out there wondering whether they should start doing things they haven't been doing for the past few months?
I mean, it's what I advise my patients when they ask me is go out, go for walks, but be careful. Try to social distance, keep your distance. Ideally, if you meet up with people, meet outside up, because we know the circulation is so much better than inside, obviously, and you shouldn't do this anyhow. But you should need to be still careful. You need to still wear your face mask, because we know that face mask wearing is extremely helpful. And if you're in a really high-risk group, like people who are chemotherapy or post-allograft or whatever, these are extremely high-risk patients because their immune system is very poor in general. So you need to be careful. And yes, you shouldn't shield, and you shouldn't be like stuck in your room, but go out for walks, but do it at times when there's no one there, and only perhaps with your partner. And try to be careful.
Mm-hmm.
We are not out of it. And it will take another 3-4 months, and we've done it already a year. So it's just sensible to be still careful.
Chris, do you have anything you want to add to that?
No, I think that's very, very sound advice. But life is for living. Who wants to live 10 years and never leave your bedroom? But it's getting that proportionality right. And for me personally, would I be rushing off to Europe to have a holiday? No. With all due respect, if there's going to be another variant, we have exported the Kent variant to Europe, well, they could easily export something back to us, because that's actually at the moment where a lot of virus is circulating. You need circulating virus to get to variants. So I personally wouldn't be recommending to people who are concerned that they should be going to Europe. If you're not concerned and you couldn't care less, well, feel free. You're probably safe with your vaccine. But for people who are concerned, I think that's a bit mad. But I think most people just want to meet their family, meet their friends, go out for a nice meal, go to the cinema, go to the theatre. Getting on a plane and sitting there for 4 hours or whatever is not a healthy thing at the best of times, in all reality. And what people probably don't quite appreciate is there would have been pandemics in the past. A little village in China where a bat passed something on to a human, they probably killed everyone in the village, but no one from that village turned up in Scotland or England on a flight that took them that far. We are very much living a life which we haven't lived before, and with that comes risks. So for me, it's proportionality and look after yourself and be careful. I don't know what Paul's thoughts are, but certainly at the beginning, we were very concerned about surfaces, catching off letters, the food delivery, etc. That seems to have abated as an issue, but I think that's probably because people are more careful and they do gel their hands and they do wash more, etc. I would keep up all those things. And I'd recommend keeping up the mask wearing. And as Tobias says, if you can meet outside, do meet outside. But I think one of the things is the school children. That's going to be, if we're going to sit, they're not being vaccinated yet. Is the vaccine going to work so well that we're not going to see the spread from children to adults and grandparents? And that's when the UK government say we want to do it step by step and see what the consequences of each action is. I think a lot of what they know, our Achilles heel, is children at school are not vaccinated. Their personal hygiene may not quite be the same as others. And therefore, if we're going to see a problem, it's either going to be school kids or it is going to come from another country.
Yeah, so I guess a good summary then is, if you're considering whether to do something, is that interaction involving unvaccinated people, children, for example, but also other unvaccinated people, and then think about how COVID transmits as well, and whether that activity is high risk. Is that a fair summary?
Yeah. If you're going to meet your grandchildren, maybe you do meet them in the park, maybe you do meet them in the garden, and you just be sensible until it's Tobias says. I think by the end of the summer, we'll have a much better feel for A, have we really got on top of this? And B, is there another threat just looming coming our way of a variant which makes us think the vaccination programme is going to be suboptimal?
Paul, is there anything you wanted to add on the transmission? One of the questions we did have in advance was, do we know anything different about the transmission of COVID that would change this advice for people who want to go out a bit more now?
I thought that was a lovely summary from Chris, really humane and wise, and I thought it was absolutely great. There's nothing to add to that, except, yeah, as Chris said, I think probably surfaces are not as high a risk as we thought, but I mean, this is not to say we shouldn't stop washing our hands, and I do that now, and we must stick to that, but it's probably more droplets and aerosol transmission as time goes on. We're understanding that now. That's about keeping away from people when you go out. Obviously, somebody was talking about being upstream rather than downstream, and wearing a mask. But as Chris says, proportionality and personal balance are what's key here.
Mm-hmm. I think of the one group where this advice is particularly tricky is for those who perhaps don't have as much choice in their contact with people, and that's people who are at work. And I wondered if I can go back to you, Tobias and Chris, and ask, what do you advise your patients who have to go back to work, or is there anything they can do to reduce their risk in these situations? Tobias, you go first, you're unmuted.
I mean, that's it. I just normally say you have to go back. There's good reasons. There's also financial reasons. I mean, a lot of people have been under significant financial duress through this one. I said, try to keep your distance, wear face masks, and be sensible. Wash your hands, all this kind of things. And by doing this on its own, you probably already have a good chance not catching it if you wear the face mask properly and everything. And that's what you have to do. And obviously, if there's someone coughing, they need to then ideally not come in. The people need to be aware that they need to be sensible at work. And there need to be clear policies regarding this one. But that's something you need to see. And if the patients are at risk, a lot of patients are able to speak to their managers, their line managers, and say, I'm at risk due to this one. And they often get actually something. Some of them are able to work from home, which is obviously the ideal scenario. Some are able to work for 3 days at home, 2 days in the office. And some people who normally would have had to commute, they just can do it via Zooms. So try to do everything you can to try to avoid contact to people you don't know. Because that's the ones who might be in the rooms with them for a long period of times.
Yeah. Are there any particular groups of patients so for example, we've had a question from a transplant patient that you would say absolutely don't go back to work at the moment, it's just not advisable?
I mean, yeah, allograft patients, we would normally say at least 6 months, ideally a year, they shouldn't, especially with this current situation, they shouldn't go back to work because they are extremely immune suppressed. Not so much the autograft patients, but the allograft patients, I mean, is immune suppressed. Those ones are at high risk. And we had people dying of COVID, post-allograft and also post-CAR T cells. And some people, I mean, that's the weird things. We had some people with post-allograft 3 months out had COVID, and we thought, oh, that's a disaster. And they just never had any symptoms. I mean, we were just surprised. And then some people where we thought, oh, this will be easy, and they became quite very unwell, ended up in intensive care units. So it's you cannot predict it always. I mean, despite everything you have, you cannot predict who will have a bad outcome and who hasn't got a bad outcome. Obviously, our treatments have improved. There's no doubt about this. We know that steroids work. We know that oxygenation works early on and things like this, and you get less patients now need to go to intensive care unit due to this kind of measures and just good supportive measures. Things have improved. There's no question about it.
Chris, anything you wanted to add on the question of work?
Well, two things really. One is, of course, all employers have a duty of care to their staff. So if you really, really do have concerns, I would speak to your line manager or your union representative and see whether actually they can accommodate your wishes, maybe to stay at home more. I touched on school children earlier, of course. We now, a lot of children being tested at school, or teachers are being tested at school, and teachers are being vaccinated. So those lovely children we have that come home every day may bring the infection into the house. That is getting safer as well with testing. There's a lot of discussion with the lateral flow test, how good it is and useful it is. But it does tell us something about the illness. And again, if your employer's being unreasonable, you could ask if there's any chance of being tested. If it is in an office, can it be rearranged if you work in different parts of the office, different times of the day, or extend the working day, come in earlier, go home earlier? So that exposure to other people. I think it's trying to have a meaningful dialogue. And I think, to be fair to most employers, they've been through this as well. This is very personal, I think, to everyone in this country. We've all got siblings, we've all got loved ones, we've all got friends. It's affected everyone. So I think just having a rational conversation with them and just seeing how you can come to a compromise that puts your mind at rest. Because is there a real risk, or is there a perceived risk? If there's a perceived risk, that can actually still affect your mental well-being. So that's not good either. So just try and discuss it with them in a grown-up way.
Great. That's really good advice. And another question we had was, how involved can or should doctors at hematologists be in this decision making, not just about work, but about the changes that people are seeing in terms of restrictions lifting and things? Tobias, how are you open to having those conversations with your patients about what they should and shouldn't be doing if they're still a bit stuck?
I mean, we can just give advice and tell them what we think is the best in this, and this has to be individualized. There's not one answer for everyone. And this is based on when they had their treatment, what treatments they had, what underlying disease they had, and also their special circumstances. Do they have any support families? Do they have anyone around? And that's in financials. All this has, and this is something we can just give advice, but ultimately it's also the patients need to make a decision. We can give some sound advice what we think is the best if they need to go back to work, how to protect themselves. And obviously what we also do is we try to speak to the GP and see if they can get up the list to get their second dose and things like this. And occasionally we are successful. But it's a bit of a luck. You cannot just push everyone up. I mean, it depends a bit on the circumstances.
Chris, anything you wanted to add on that?
Yeah, can I just add as well, something we haven't touched on is there are new treatments coming along for COVID. There's the ones we know about, the dexamethasone, the tocilizumab. There's some really exciting data with monoclonal antibodies, which job is to actually bind to the spike protein. And if people present early, the results look very good. Regeneron, Eli Lilly, GSK, Sanofi. We're going to see in the next 2-3 months much better therapies coming out than we've got already. So there's that side of the equation that's been going on. So even if you do get COVID, there will be better therapies awaiting you in the NHS. What everyone fears is going back from whence we came. And I don't think we will be. We've learned an awful lot. we have better therapies, we've got a better idea, we know how to manage people with respiratory failure, we know how to try and prevent the thrombosis side of things. So on the positive side, the rest of medicine's advanced as well. We're rightly talking about vaccines for obvious reasons, but the other therapies are all coming along as well, and they look very exciting.
Yeah, I think that's a positive for everyone, not just blood cancer patients, but for those most at risk, it's a good thing to have in the back of your mind. I think we've covered the vast majority of questions now, and I know Paul's answered some personally. Thank you for that, Paul. I appreciate everyone's got individual circumstances that they'd love a specific answer to, but I think today's outlined that some of these questions can't be answered yet. It's too early to know. I would encourage everyone who still feels unsure to speak to either us at Leukaemia Care or to their haematologist for further advice, or their nurse specialist or someone in their care team for making any changes. I hope this has been useful to everyone, and thank you to our panel for answering what you could today. If we could have the slides, please, for the end of the webinar, that would be great. I think I may have taken my colleague by surprise by ending the webinar. While we're waiting for the slides, one thing, there we go. One thing I did want to say is what the one aspect that's really important that we haven't covered today was sort of the emotional and psychological concerns about coming out shielding and around COVID-19, which we appreciate is really important, but we did cover it fairly recently on a separate webinar, so we made a conscious decision not to cover it today. And if you do have any concerns about that, please go refer back to our previous webinars. If you just search webinars in the search box on our website, it will come up with that webinar, which I believe was called The Impact of Shielding. So hopefully you'll find that useful if you did have any questions around the emotional and psychological aspects of shielding and COVID. So just to finish up for today then, if anybody's looking for further information on COVID or anything related to leukemia, we have a variety of information sources. One particular one I wanted to mention, next slide please, is the podcast. We recently did a discussion on the end of shielding. We've written several podcasts on shielding at various points throughout the pandemic where we thought we may be the last time we talk about shielding. I'm hoping this genuinely will be the last time we speak about shielding on the podcast in terms of it being in place. But if anybody is looking for sort of others' experiences on how they're coping with coming out of shielding, I'd really recommend that as a good listen. Next slide, please. Obviously, we've also got a variety of support services. If you did want to talk through any of the topics we've covered today, or indeed anything else related to leukemia, please get in touch with us via our helpline. Any specific concerns around the going back to work and your rights and what your employer should be putting in place, our welfare officer is able to help with that. So I know that's been a very, very common question, and please do get in touch. Next slide, please. And as I said a moment ago, the emotional and psychological impact of this time, especially for those who've been shielding, has been extremely acute. So I just wanted to remind everyone that we do have a counselling fund where we fund up to 6 sessions of counselling for people with leukemia and a few other rare related blood cancers. So please do get in touch if you think you need support as we sort of move into the next period of the COVID-19 pandemic. And next slide, please. Here we go. We'll just leave that up while I finish up with another thank you to the panelists today for your time. I'm sure everybody found it really useful. There's plenty of thank yous coming in through the chat box, so everyone's found it very, very helpful. Thank you everyone for attending today, and we'll see you at the next webinar, hopefully. Have a lovely afternoon. Thanks all.
Thank you very much.
Thank you.
Great.